All right, Dr. Turnpaugh, we are live. It looks like everyone who was waiting is now moving in to the webinar. So I want to welcome everybody this evening. Thanks for taking some time out of your Wednesday night with us for another super educational webinar. Tonight we have Dr. Chris Turnpaugh. And Dr. Turnpaugh is a practitioner in, I believe you are in New Jersey. Is that correct, Dr. Turnpaugh?
Actually, Pennsylvania, Mechanicsburg, Pennsylvania.
That's right. That's right. So Dr. Turnpaugh's primary focus is finding and addressing root causes of disease. He graduated from Life College of Chiropractic, received his postdoctorate in functional neurology. His interest in functional medicine began with the intent on helping a current patient who was looking to address his whole health after an ALS diagnosis. And then after attending a seminar in 1995 by Dr. Jeff Bland, who everybody should know who that is, he's kind of considered the father of functional medicine, he was really hooked on the concept of functional medicine, and that began his career in root cause medicine. And so tonight's webinar, obviously, we're talking about true root causes of neurological dysfunction or neurological inflammation. So he opened Turnpaugh Health and Wellness Center in 1999 and has extensive experience in supporting patients who are dealing with the most difficult chronic autoimmune and neurological health conditions. And you, I understand, Dr. Turnpaugh, have a personal history of experience as well with supporting Lyme disease, autoimmune, Fragile X, as well as experience with pediatric neurological conditions, thyroid, hormone conditions, and a whole host of other stuff.
Correct.
Yes, I am going to turn it over to Dr. Turnpaugh here. If you are a listener and you have questions during the webinar, please feel free to type those into either the Q&A or the chat, and we will get to those at the end. We'll have about 10 to 15 minutes to cover questions. I'm sure you guys will have a lot of really good questions this evening. Yes, this is recorded, and we will post a recording in our provider portal, as well as email a link to the recording generally within 48 hours or so. And we will make slides available too. Usually those are the biggest questions people have right off the bat. So Dr. Turnpaugh, I'm going to go ahead and mute myself.
Okay.
Okay, and let me know if you have any trouble with any of the slides or the audio.
Sounds good. Thanks so much. Appreciate it. Any questions you guys have, I'm totally interactive, so feel free to ask them along the way, and she'll ask them, pop them up. I'm going to go through, we're going to talk about the NeuroZoomer tonight, and when you might want to use it, what it means, why would you order it, those type of questions. That I think is what I want to try and delineate. It's a pretty extensive and comprehensive test. It can be a bit overwhelming if you look at it at face value. What I want to try to do is break it down into why you would order it, when you would order it, what it means to order it. And it starts with what's the mechanism of what's going on with the patient. So if you have a patient come in and you're considering, you have to ask yourself, why would I order a NeuroZoomer? What's going on with this patient? So I'm going to walk through, hopefully, some pretty rudimentary ideas or basic ideas. And from there, we'll try to build up and crescendo up to the NeuroZoomer. I'll break it down a little bit. I'll go deep into one of the biomarkers like aquaporin 4, kind of come back out the other side. And at the end, we'll do a real life case study, which may hopefully show the significance of what the NeuroZoomer can teach or help facilitate in the care. So what I want to start with is immune activation, and we can have immune activation from many different causes. The immune activation can happen from an infection, a toxin, a food, a stress. If it's an autoimmune condition, it would be a mold or a mycotoxin. All of these conditions can drive the immune system and should drive the immune system to be activated. And then if they're activated, so if you have an infection and you get immune activation and then it resolves, you get resolution, those are typically not the patients we see in our office. Most of us see in our office patients that come in who've had a generic term, immune activation, and it has not resolved, or what we call lack of resolution. So an ongoing issue. They're the ones that typically come in. So if you get a cold, you get a little bit of a fever, a little bit of inflammation and it resolves. That's not what we're talking about. We're talking about the people that have a chronic issue, a chronic health issue. They're the ones we're more likely to consider the neural zoomer on. So what will happen is you'll get an unresolved immune activation, which will trigger inflammation, which can also trigger autoimmunity. And we may know these in different terms. So you may have, instead of inflammation, you might call it NF-kappa B, and instead of autoimmunity, you might call it STAT3 activation. These are markers, they feed off each other. So inflammation can drive autoimmunity and autoimmunity can drive inflammation. And both of those would be defined as an unresolved immune activation. So this is what we're looking at what is going on. I have a little bit more complicated picture. The next picture is my entire life on a slide, and I'll try and break it down for you. But the key is, why do we have lack of resolution? So, and we can talk at length over weekends about what to do for unresolved immune activation, but we want to at least understand the premise that it's an inflammatory response, which can lead to autoimmunity, and then the autoimmunity can lead to inflammation. It can start from a trigger and mutate into something different than that trigger, so it gets confusing. So the next slide, this is my life on a piece of paper. I know seems like a lot. We're going to break it down. The next slide actually breaks down what can trigger it. So you have infections and toxins and mycotoxins and food and stress and you. So this whole process of an inflammatory response can be started by many different vectors. So we start over here, which most of us know, and this is probably a bit sophomoric for many, but we have our gut barrier here. And most of our immune system lives around our gut. It's the gut-associated lymphoid tissue. So we have our GALT here, and we have our gut barrier. And we've talked a lot about this, especially in functional medicine. So we have these peptides of these foods here. They should get broken down into their teeny tiny pieces and come into our body. They're met here by a border patrol. If the border patrol says you're allowed to come in, that's great. If it doesn't, it activates the immune system. So our number one environmental influence over, except for the food that we eat, or the air that we breathe, is probably the food that we eat. So this is a number one environmental influential factor that we have. So food presents to the immune system all the time through our GALT, but an infection can do it. Certainly a toxin, a mycotoxin, a mold. Stress activates this as well. And if it's an autoimmune condition, it's you. So these are presented, these little pieces. So the body goes in and rips a piece of the infection off, let's say, and then that piece is presented to the immune system through an antigen presenting cell. And it presents to what's called a naive T cell. A naive T cell is a cell that's not sure what it wants to be when it grows up. So it can grow up to become a Th1, a Th2, a Th17, a Th9, 22 follicular cell, or a T regulatory cell, which sometimes is called a Th3. So these letters and numbers have become popular in the nomenclature recently. So what will happen with most of these expressions is we'll get some inflammation down here. Remember, we said that autoimmune disease and inflammation feed each other. So if we were to go back, simplistically, we get inflammation driving autoimmunity and autoimmunity driving inflammation. So here, we're going to get these feed forward cycles between the two of these. What's really driving this mechanism a little bit deeper, and if you don't follow the whole thing, it's fine. And if this is review, that's fine as well. If a naive T cell grows up and becomes a Th2, or you have Th2 dominance, that's going to drive Th17, which is going to drive autoimmunity and cancer, as well as other issues we have down here. If you get an infection, let's just say you get Lyme disease, which is common in my neck of the woods, you get Lyme disease, it'll drive a Th1 response, or should drive a Th1 response, as well as a natural killer cell response. These fight infections. If the Lyme disease overpowers this, we get a Th1 suppression. Th1 kind of goes away. Another job Th1 has is to inhibit or shut off Th2, which in turn shuts off Th17. which in turn shuts down autoimmunity. So these are the mechanisms that we talked about. So you can get an infection, which goes to Th1, even if you fight the infection off and win and beat the infection, but the cost of fighting the infection depleted your Th1 side of your immune system. You're going to become Th2 dominant, Th17 dominant, and you could develop, it increases the probability to develop Th17 or autoimmune disease, I'm sorry. Now, you can get an infection-driven autoimmune condition, and you will mimic the infection in the absence of the infection at times. So you can still feel like you're infected, but really it's your immune system attacking you, or you may have an ongoing infection, and these are critical. What we can do is we can identify the infections, the toxins, the mycotoxins, the food. Sometimes we can isolate the stress. And then we want to know, is it also affecting you? So that's where the neurozoomer comes in, is what is the mechanism of what's going on? The neurozoomer for me in my practice is not done in a vacuum. It's done in conjunction with other tests. So I think that's the important takeaway. So the NeuroZoomer Plus is best utilized as a predictive or confirmatory test used in conjunction with additional testing to facilitate the reduction of mechanistic pathways. What does that mean? Essentially, you can use the markers that are found on the NeuroZoomer Plus as a potential predictor of where your patient might be heading. So if you see autoantibodies to certain neurologic tissue, that's a predictor of what may be coming down the road. It also may be a confirmatory marker that's already been here. Now, traditionally in allopathic medicine, these antibodies are used as confirmatory tests. Somebody comes in, they look like a duck, they act like a duck, we're going to see if they have antibodies to a duck. Then you can say, okay, we are confirming your diagnosis, but it doesn't help give any kind of useful strategy many times. It doesn't give us the mechanism of action. If it's a predictive antibody, that says, you know what, we need to change the course of action. We need to pivot your healthcare. If we don't pivot your healthcare, there's an increased probability that XYZ is coming down the road. And that's where the NeuroZoomer is helpful many times in understanding as well as patient compliance. So this is how I use the NeuroZoomer. So the NeuroZoomer, one of the rationales for doing it is you have symptoms associated with some of these conditions. So what I would say about that is, on clinical presentation, do they have neurologic symptoms? And the name of the disease isn't that important to me at this point. So do they have cognitive decline? Do they have brain fog? Is it memory loss? I'm not looking for a named condition like myasthenia gravis. I'm looking for, do they have a neurologic symptom going on upon clinical presentation? If they do, is that from simple neural inflammation? Is that from a circadian rhythm issue? Is that from a blood sugar issue? Or is it truly linked to autoimmunity? And they have, in my world, they have different rationales for treatment, different protocols and different objective markers to look for. So if it's an autoimmune situation affecting brain, I might support that patient differently than I would support somebody who has a blood sugar issue that has brain issues. So hopefully that resonates and we can say, okay, why would I order this? What's the difference? What's the mechanism of action? If the mechanism of their neurologic issue or encephalitis is not autoimmune in nature, but it's infectious in nature, if their memory loss is due to a circadian rhythm issue, or is it due to an autoimmunity issue, it's going to help me delineate what the best way to support that patient is, or at least what pillars I need to support that patient. So if somebody comes in with memory loss and it's autoimmune in nature, we need to find the triggers of that autoimmune condition. If the patient comes in with memory loss and there doesn't seem to be any neurologic autoimmunity at that moment, that may mean a different course of support. So I'm not going to bore you with all of the tests that are done in detail, but I'm going to go through them just so you can potentially understand what some of them are. You have your peripheral neuropathies here. They kind of group them together. This is all available to you on the Vibrant site. Some of these tests will, like these tests, for example, a lot of them are tied to cancers. They can be tied to breast cancers. They can be associated with brain inflammation and psychiatric issues. You don't have to know what each test means. So you'll get lost in the weeds. You'll get stuck in, this is too intimidating. I don't know what an anti-Hu or an anti-Re test is. You don't have to know what all of those are in detail. But it's important to know that it's autoimmunity. You look at these type of tests and you'll see some brain swelling issues, maybe some bipolar issues, maybe some encephalitis issues, and they do characterize it. And I think it's important to maybe step back and not get so deep and look at the blue marker at the top and say, okay, this is indicative of brain inflammation. This one's indicative of peripheral neuropathy or something peripheral going on. And then they give a little cheat sheet at some point. So if you see some of these receptors, hey, these are helpful in diagnosing patients with symptoms of ocular or motor or brainstem dysfunctions. And then it's really your wheelhouse. Do you know how to tease out a motor dysfunction or a brainstem dysfunction? So you're not looking for stiff person syndrome or maybe myoclonus, but if you're doing a physical exam and you see some clonus going on and you run a neurozoomer and this receptor comes up, you may say, hey, your clonus is actually not just what we maybe thought it was. It may be indicative of an autoimmune upper motor neuron lesion, and I might want to run a neurozoomer on you to see what might be going on. Some neuromuscular disorders you'll see here. These, if you look into the literature and look what these receptors, antibodies mean, you'll typically find the end stage pathology of these diseases. So these may be related to things like myasthenia gravis. But we don't want to wait till a patient gets myasthenia gravis to say, let's do something about that. We want to look at these markers and say, if we don't pivot your healthcare to a different trajectory and try and quiescent these autoimmune markers in your brain, there's an increased probability you're going to head towards myasthenia gravis type symptoms. And it's incredibly powerful to tell a patient, I have a benchmark, a marker, an objective finding that says we need to pivot your healthcare, change your healthcare direction so that you don't wind up suffering one of these quote unquote irreversible autoimmune conditions. We want to do things now that are preventative. And in that manner, these markers are predictive or suggestive or increase the probability that something may be coming down the road. Some of these are infections that tie into brain inflammation, brain swelling, or polyreactivity. So you can get one of these infections and it can trigger an autoimmune flare of the brain. These are very important to know so that you can manage the potential pathogenic burden. That is to say, if your viral load is so high that it's causing some of these things, you can get brain inflammation and brain swelling along the way. Kind of knowing the mechanism. Again, you have these cheat sheets available to you from Vibrant, but it might say something simple, like if you check a herpes simplex 1 or 2 and you're getting eruptions, then you need to support that mechanism. But if you don't support that, then what's going to happen over time is you're going to develop brain autoimmunity. All of the antibodies all of the viruses that are checked, they cross-react with so many different parts of the body. You can look at these and see if many of these are, in my neck of the woods, are valued in tick-borne illness. And so we see the HHV7 goes with Lyme disease, and you might have Epstein-Barr and all these different things that are causing brain inflammation and lead to autoimmunity to your own brain. It gives a clue as to what might be the mechanism of support. So do we need to do some viral support in this? Now, the anti-streptococcal A, we'll get into that a little bit. I wrote a paper on that, which is in the presentation here. So what happens is you'll get strep throat. Your body confuses the strep bug with your brain tissue, and it attacks your brain tissue. And these antibodies get turned on more every time they see strep. So, and it cross-reacts with foods as well. So again, these are just, I will dive a little bit into aquaporin 4. You'll see down below here, aquaporin 4 shows cross-reactivity with corn and soybean, as well as tomatoes and spinach and tobacco. So if somebody has an aquaporin 4 antibody and they continue to eat their spinach and they react to spinach, every time they eat spinach, they're activating brain autoimmunity. That's not good. More brain, I'm not going to go through them all, like I said, but these are more brain. Some of these are going to affect neurotransmitters and excitatory actions. This is blood-brain barrier. These are things that may show up on patients who have concussions or traumatic brain injuries. This could be used by college athletics or NFL football players to see if they actually have blood-brain barrier disruption secondary to a concussion, which has led to an autoimmune reactivity. So then you can tell that player, hey, you have an auto antibody to your own blood-brain barrier or your microglial cells. If you irritate or inflame that again, remember early on, the inflammation drives autoimmunity. So if your autoimmunity is at a low level, but you triggered it from a concussion, and then you get a second concussion, which drives inflammation through the roof, you're going to turn on your autoimmunity. So now you have an autoimmune condition triggered or exacerbated by an inflammatory response, which you could have predicted had you run this test. Demyelinating antigens. So this is not only MS, but peripheral neuropathies or any of your myelin antibodies. GABA antibodies, these are, you might suspect these in patients who have anxiety, or they might have type 1 diabetes, the two that go together. And it doesn't have to be full-blown psychiatric anxiety, but if you see that they have some of these GABA antibodies and they have GAD65 antibodies, you might find some movement disorder, but you're going to find a lot of anxiety secondary to autoimmunity. And if your mechanism of support for that patient is just from an anxiety standpoint, we're not going to get to the core or the root cause, which is really an autoimmune condition. The same with NMDA. You might have migraines or people who have chronic head pain or inflammatory responses. And if we're thinking it's only an inflammatory case and it's actually an autoimmune case, we're going to miss the mechanism of action. Your dopamine receptors can certainly cause any kind of focus issues. So if we think of dopamine in a classic Parkinson's patient, they can't stop themselves from shaking. But we see this in children with ADD and ADHD. They can't stop themselves from moving. And if that is more than a behavior disorder, it's actually an autoimmune disorder, then our mechanism of support is going to be different. We find some of these in Parkinson's disease, Alzheimer's disease, and vascular dementia. So it helps. The reason I'm kind of going through these, you don't need to know what each one of these is. You just want to know they're associated with other conditions. And if your support is, if somebody's balance is off because their cerebellum's off and you're doing balance exercises with them and you say, well, actually you have an autoimmune condition which affects your cerebellum, and that coincides with your wheat intake or your dairy intake. So every time you eat wheat or dairy, it triggers your cerebellar antibodies, and then your cerebellar antibodies trigger vertigo or dizziness or balance issues. The mechanism isn't going to be support, just balance. The mechanism is going to be cut the wheat and dairy out. Any questions on that so far? The same thoughts we're going through. I don't know if we have any questions yet.
We do have a few. Do you want to go over them now, or do you want to hold?
Well, just briefly. So what I'm going to go into now is like a little bit of cross-reactivity with foods and group A strep, which is lead to pandus, and then maybe some aquaporin. I want to make sure we get, this is really for you guys. So I want to make sure we hit a couple questions now, and then we'll maybe hit a couple through. So it may be more relevant at this point.
Sure. Okay. One of the questions was, is this, or could this also be used for old brain traumas?
Well, that's a great question. So remember the first slide, I try and keep everything pretty simple. It keeps me grounded. If the condition hasn't resolved, so it's lack of resolution. So if you have an old brain trauma, do we know it's fully resolved? So if you have a blood sugar problem, we can tell if that's resolved because we can run a blood test and see where your blood sugar is. But if you have a brain trauma, I can't tell what's going on with your microglial activation or glial priming. I can't see that. So it's very likely that you can have an unresolved brain issue from a previous concussion. And the best way to know about that might be to run one of these tests. And then we want to find out, well, what else can be done? Because clearly you didn't completely resolve from your previous brain trauma.
Great. Okay. Another question was, what are your go-to therapies for healing the blood-brain barrier? I don't know if that's something you're going to cover tonight.
I might cover that. I think that that's important. I think that's a deeper question.
Right.
But let's just gloss over and say, well, if we have a blood-brain barrier issue which has led to autoimmunity, two things need to be downregulated. One, my autoimmune response, and two, my inflammatory response in the brain. Whenever you have a breach in the blood-brain barrier, you're going to get a massive immunological response and a massive inflammatory response. The brain lives in what's called in the literature a privileged position. It's privileged because the rest of the immune system cannot see it. It's behind this magical blood-brain barrier. And so the immune system can't see it. It's privileged. So when you breach it, which by definition, if you have a concussion, you've breached your blood-brain barrier. When you breach it, now the immune system can see it and it's no longer privileged. It's no longer in the big house behind the wall. That triggers a massive immunological response and an inflammatory response. So I'll talk about that at the end. If we do, I'd love to go into more detail. We wrote a pretty detailed paper on concussion, but whatever strategies you use to reduce inflammation are going to be important.
Great. All right. Let's do one more and then we can jump back in.
Okay.
A question from Lisa was, how long do these antibodies hang around? So does the patient need to be tested while they're in a symptom flare, or will they stay positive afterwards?
So with antibodies, if we're talking about IgA, IgM, and IgG, we'll talk about the M antibodies. The M antibodies will stick around for about 3 months. They'll come pretty early. The G antibodies will typically come from 6 to 9 months, and they start to degrade after that point. They vary on everybody, but that's pretty common standard in the literature. Now, that's upon exposure. So if you have an exposure to an infection and the infection's gone, then you can start the time for those to go away. Your M antibodies, they come upon exposure and then they degrade even with presence of the antigen. With self-tissue antibodies, they may not go away because remember, they go up upon exposure. So if you have thyroid antibodies, as long as you have a thyroid, you may have antibodies, right? If you have blood-brain barrier antibodies, as long as you have a blood-brain barrier, you may have antibodies unless you get to the secondary mechanisms which are driving it.
All right. There's more questions, but we can absolutely.
Okay. So this is a paper that I co-authored, and it was, I'll give you a brief background. I was in Italy lecturing on pandas with Sue Sweeto, who named the disease pandas, and Madeline Cunningham, who came up with one of the first tests for it. And so we're sitting around afterwards and we're having a powwow, and somebody said, do you think anything else can cause pandas other than strep? And some of the clinicians were saying, of course, other infections can do it. Me, with my background, I said, I think foods could do it. And they all agreed foods could do it. And I said, well, let's do that. That's pretty simple. The large consensus was there's no money in testing for food because the therapy is just change your diet. So that's what started me on the path to do this. So we checked to see if antibodies against strep could cross-react with your brain and cross-react with a food. That is to say, maybe you got a strep infection and you attacked your brain, and then you ate a food and it continued to attack your brain. And I can tell you firsthand, we use these markers in the office, and I'll just briefly go through them. You don't have to memorize them all here. The paper's published. So we tested it against 180 major foods. And here we find that with dopamine receptors, things like eggplant, things like cashew, things like soybean, rice protein, bell peppers, these are all statistically significant potential cross-reactors with brain tissue after a pandas flare. We see here things like mint and thyme. And thyme is typically used as a natural remedy for infection. But if you give thyme to somebody who has an infection like strep and it cross-reacts the brain, you're going to trigger a brain reaction. So goat's milk was pretty high. Wheat is always high. Here we see mint again, and thyme and cherries and things that may seem healthy. Here we see egg whites cross-react with strep. I saw one on here. Yeah, asparagus will cross-react with the GM1 antibodies. And so who would think that asparagus would be one of the things that's the highest, or mustard seed? So these are foods that we need to evaluate to see how they react to you. And if you have the brain autoantibody, if you don't have the brain autoantibody, then it doesn't matter. And so it's not that these foods are good or bad. They're only bad or good in the presence of the cross-reactivity. And then we have the aquaporin 4 antibodies. The big takeaway of aquaporin 4, I'm gonna cruise through a couple of these slides pretty quickly. Aquaporin 4, we don't want to wait till you get neuromyelitis optica until we start to do something about it. We don't want the extensive myelitis. We don't want this to progress to this point. And this is where the literature takes us. But what we can say is, if this aquaporin 4 is predictive of you developing this, let's do something before it gets there, right? So this leads to astrocyte degradation around what they call the nodes around VA, and causes demyelination. And if we see here, it's an autoimmune condition which leads to edema and inflammation. So edema and inflammation are prominent with IgM and IgG. Your antibodies are there, and that drives inflammation and edema, and they feed each other. So our mechanism of action should be something to do with autoimmunity, something to do with edema, and something to do with inflammation. They're antibody dependent and cell mediated cytotoxicity. So they get inflammation and they get autoimmunity. Things to think about that come in your office: intractable vomiting, but intractable hiccups. So I've seen this a couple of times where they have these hiccups that just don't go away, and it could be an autoimmune condition. So I might say today, and maybe not 15 years ago, but I might say today, for a patient that just gets hiccups all the time, hey, maybe I want to run a Neurozoomer Plus on you and see if you have aquaporin 4 antibodies. And then maybe we need to cut out foods that you cross-react to, like spinach and tomato and potato. So you might get some weakness or numbness in the limbs. You might get some visual disturbances. These are things you're going to see before you get the full-blown disease. And this might be predictive. Hey, people come in, they're complaining of limb weakness or numbness. They get these weird pains or weird vision issues. Maybe I'll run the Neurozoomer Plus. So we want here they talk about intervention and treatment can further prevent the disabling complications of the disease. I have a big phrase in my office: we want to get to it before it gets to the patient. So we don't want to wait till it gets to the patient until we do something. So I say to all the clinicians in the office, we want to get to it before it gets to them, whatever it is. One of the ways to determine what it is to figure out the mechanism of action. If the mechanism of action is an infection-driven neurologic autoimmunity, I need to see all those steps. Here's another published paper that talks about corn, soybean, and spinach and tomato. They all have aquaporins, which are very closely related to human aquaporin. The other one is tobacco. So for people that chew tobacco, those are 4 that you want to maybe think about. So it says here, they showed the percent of neurologic tissue antibody production increased with the number of positive food aquaporins. So the more food they have with the aquaporins, the more reactivity there is in the brain. Interestingly, spinach, Popeye would not like this slide, right? So Popeye should not be eating his spinach if he has aquaporin 4 antibodies. Aquaporins are these, I'm not going to spend too much time on aquaporin because it's not aquaporin lecture, but aquaporin are these channels that allow for water to get in and out of the cell, or they're channels for different electrolytes to get in and out of the cell. So this is important for people that have swelling, not just of the brain, but of their ankles, or they have electrolyte imbalances, metabolic disorders like cancer and neurologic diseases, and chronic inflammatory cases, which walk in our office all the time. And the literature tells us that we have bioactive phytocompounds which can help this. And then I just was cruising through this and I thought, many of us use curcumin as an anti-inflammatory, but if you have an aquaporin 4 antibody, or if you have lupus, you may want to think twice about it. So I just threw that in there. So this is kind of a crash course in the NeuroZoomer. But what does it really mean? I'm going to tie it into a case here. And the case is an actual patient. And I hope to tie in what's the mechanism and what might be going on. So if you suspect somebody comes in with neurologic signs or symptoms and you want to know, are those just inflammatory? Are they due to blood sugar? Are they due to anemia? Are they due to mechanisms outside of autoimmunity? Or are they really primary autoimmune reactions which are coming on as a consequence of something else? That's the differentiating fact. So I'm going to go out of this. Bear with me for a second. And I'm going to go into a true NeuroZoomer. Okay, let's see if I can get up to the top here. So this is I'm sorry, not a NeuroZoomer. This starts as a tick zoomer and the case will evolve. So this is someone walks in with neurologic symptoms, not sure what's going on. We do the tick zoomer, and the tick zoomer shows me that I have some reactivity to Borrelia, and we get a positive finding of Lyme disease. Okay. And we don't find a lot else, so we're pretty spot on that we think that something's going on because that's a unique marker and not everything's lighting up. Then at the same time, we do a NeuroZoomer, and we see here, we see demyelinating antigens, we see those aquaporin 4 antigens, neuromuscular disorder antigens, and HSV1 and HSV7. So we have to say, well, you might have a tick-borne or a tick infection driving autoimmune disease, which may lead to things like multiple sclerosis or visual disturbances, peripheral neuropathy. And what we also said is, if you have aquaporin 4, you might have inflammatory problems. You might have what looks like electrolyte imbalances. So you might have swelling and edema that comes and goes. And that may be triggered by things like spinach, tomatoes, corn, soy, if you're eating them, but I don't know if you have reactions to those. So we already see a conjunction between possibly a tick-borne or a tick illness driving autoimmunity to brain. So if this person comes in with burning pain, symptoms of multiple sclerosis, extremity weakness, fatigue, brain fog, and we just do the NeuroZoomer Plus, and we miss the fact that it was a tick-borne illness, we're going to miss one of the mechanisms. Now, we could get rid of the Lyme disease, and they still might have these going on, but at least we know we've removed one of the drivers of this autoimmune condition. Same patient. And now we did food sensitivity testing on the patient. And they have some foods that we know are triggers. So we see things like dairy and gluten alternatives. So these are foods that are going to drive the immune system to become more autoimmune. Autoimmune drives inflammation. Inflammation drives autoimmune. What's the risk for this patient? To develop these nasty diseases because they had Lyme disease and these food reactivities. What came first? I don't know what came first, but I do know that I want to avoid all potential triggers. I can't cut the brain out of this gentleman, but I can cut the foods out, right? So that's important. It's also good to know what they don't react to. And then you get the pretty little pictures of all the different foods and what to eat and how to do it. If you've ever seen the rest of the Zoomers, they're great. They go through the whole mechanism of what you can and can't do and potential foods to do. I think we're all familiar with that. We also did a grain zoomer. Go back to the top of this one. So here what we find is in this patient, their total IgG or IgE and IgM is through the roof. So the reference range here is 87 and they're 872. And then we see the IgM is lab low because everything is being depleted. The other immunoglobulins are being depleted to other areas. So this is a highly inflamed roasting patient with what many would say has allergies or possibly some parasites or something like that. But this is someone who has a massive, smoldering, smoking, firing, flaming immune system. And what could be the consequence of this? Well, we could say, hey, it's just allergies, or you're going to get MS. So that's the rationale for doing the NeuroZoomer Plus, is we need to put this fire out, or we're going to develop these type of symptoms right here. These are predictive, if not confirmatory. So if they come in with blindness and they're in a wheelchair, they may be down that path, but we want to get to that before it gets to them. So we're going to look through and see what else we can do. We see here they test positive for things like quinoa and oats. So they might say, well, I'm gluten-free, so I do quinoa, but that's not going to help this person. And then we also did on this patient some micronutrient testing, and the micronutrient testing tells us what they're actually absorbing and what they're not absorbing. So not just what comes back on their blood tests, but also what they're not absorbing and some foods that may be reacting to it. So this is kind of a comprehensive, okay, you came in, you had neurologic symptoms, you have autoreactivity to your brain. What steps can I do to inhibit you from developing the autoimmune disorders, which are not really kind to your body? What can I do for you? And then, well, I can't get rid of your brain. This patient also reacts to spinach and tomatoes. So spinach and tomatoes and aquaporin 4, every time this person eats spinach or tomatoes, they're basically saying, please trigger an autoimmune response to my brain, which may lead to MS or visual disturbances or muscle breakdown. So that's the rationale for the NeuroZoomer Plus in conjunction with these other tests. You know, there's certainly other things you want to look at. You want to look at other inflammatory markers and support their inflammatory process, downregulate pro-inflammatory cytokines, make sure their vitamin D is good. But this person needs good sleep, good immune regulation, and removal of potential antigens, which are going to drive his autoimmune reaction to his brain. So this NeuroZoomer isn't done in a vacuum. If I just ran this NeuroZoomer on this patient, I would say, you know what? You might have some viral burden, but you actually look like you got some MS coming and some visual disturbances and some inability to process fluid inside and outside the cell. What are you going to say? Have a nice life. What are you going to do for this person? This person, what we were able to do is say, we have found co-triggers. We have found things that are going to trigger these antibodies to turn on. And one of those is a Lyme antibody. So we have to look and support Lyme disease. Other ones are just foods. And I've seen food antibodies mimic Lyme disease. And I've seen Lyme disease trigger all kinds of food responses. Most of the time, we will find self-tissue antibodies to something with chronic unresolved bombardment. So if you're chronically sick with an illness or you have a pathogenic burden, it's going to lead to an exaggerated inflammatory state. And that inflammatory state is going to promote STAT3 or autoimmune reactivity. And there's a whole host of lectures we can do on the immune system, but this is what I wanted to, or my goal was to bring to light. When can I order a NeuroZoomer? What does it mean? Do I have to know what, anti-muscle specific kinase is? In this case, not so much. You need to know what to look for as far as symptoms go, but you want to figure out what are the co-triggers that drive these. And so this person, you may make lifestyle changes. You may do some treatments or support for Lyme disease, but at the very least, you want to alter the diet. Hey, I know you were gluten-free and I know you were eating tapioca, but did you know tapioca is very reactive to you and it drives your demyelinating antibodies, which promotes the probability of you developing MS? That's the mechanism of action in this case. So, I can go deeper, but for the sake of time and answering everybody's questions, and so people get the takeaways, I will tell you, it's a bit challenging because you're not sitting in front of me. So what other questions do we have? And I can go a little bit deeper on anything.
I think we actually have quite a few. Since you're talking a little bit about infections like tick-borne, one of the questions is, how do tick-borne illnesses play a role? I think you sort of touched on it, but I don't know if you wanted to go a little deeper with that answer.
Well, there's a couple ways. So first of all, what happens is called molecular mimicry. So if your brain looks enough like a tick, so to speak, when you attack, you're going to get, I say antibodies have poor eyesight, right? They're supposed to be monoclonal antibodies, which mean they only attack one thing, but we know that that's not how they work. So much like with, I'll use rheumatic fever, which is the old strep. You get strep in your throat, your body confuses your heart for strep. So it had molecular mimicry. It thought your heart was strep throat and it attacked your heart. Same with Sydenham's chorea. That's an older diagnosis for, or St. Vitus dance, they used to call it, where people would get these choreographic movements in their brain. The brain was confused with strep. You clear up the strep, you clear up the St. Vitus dance. In Lyme disease, you have two mechanisms. One is that you have molecular mimicry. So you have Lyme disease and it looks enough like self-tissue. That's one. The other thing is Lyme is famous for burrowing into tissue. So as it burrows into tissue, as your immune system goes in and goes after it, when I said there's antigen presenting cells, so if I could take a liberty and go back to my picture here, and I'm going to go, forgive the dizzying pace we're going to do this. So here, when you present to this naive T cell, you're presenting really debris fields. So you're presenting a piece of a bug or a piece of a toxin or a piece of you. If Lyme disease burrows into a tissue and you go after it and you grab a piece of it, there's a chance you grabbed a piece of you and a piece of the bug. You present them both at the same time to the immune system. And then you have these MHC class 2 receptors, which tell you to tolerate or not to tolerate. So when you present you to your immune system, it says, hey, tolerate this. If you present a bug, you say, hey, don't tolerate that. If you present them both at the same time, your immune system gets confused and said, should I tolerate that or attack it? There's an increased probability with a burrowing infection where you go after it and there's much of a debris field that you're going to present self-tissue and infectious tissue at the same time. And that's another mechanism of autoimmunity.
Great. I think there's actually a few questions that all are kind of asking the same thing, so I'll sort of paraphrase them all together. In terms of running multiple tests, and so you made the comment that the NeuroZoomer Plus is sort of a tool, but it's not necessarily a root cause. It's more of a display of how this may be manifesting for a patient. There's other testing that you need to run for context, right? You run a fairly comprehensive initial panel of tests, and there's a few questions as far as which tests do you run alongside this? Does that vary by patient? What if patients are limited financially? Which tests are like bottom line, gotta have them? Do you have thoughts there?
Yeah, that's a great question. Like, so the case that I presented is not every case. So we live in the real world. We don't just cherry pick patients who are willing to do whatever. We have 11 clinicians in the office and we take what walks in the door, and we have to keep we have to be stewards for their wallet as well. So that's a great question. So it depends on the clinical presentation. We'll typically run the standard markers. So we're going to run, maybe you're looking for inflammation and you run something simple like a CRP or a glyc. We may look for blood sugar fluctuation because that's going to trigger this. So we might run something simple like an A1C or a fasting glucose. We're going to run a vitamin D. We're going to check for thyroid hormones, and we may check for some autoantibodies that are run through regular labs like thyroid antibodies or GAD antibodies. It's when we think that, and if they come in and we're thinking maybe they have Lyme disease, we need to look at that. That's what we're going to run the tick-borne illness panel. But if these correlate to brain and we think we've resolved the primary mechanism, and I'll just choose something we've talked about tonight. Suppose we think they've been treated for Lyme, or they come to our office after 6 months or 6 years worth of treatment for Lyme, and they still have the same symptoms. And they think, I will tell you a story. I had a patient who came in to see me after 23 years of Lyme treatment and 23 years of continuous antibiotics. And she came to see me because they recommended another year of antibiotics. And I said, well, if you didn't kill it in 23 years, you're not going to kill it in 24. And so what we found was that she had some food sensitivities and autoimmune reactivity, not Lyme disease anymore, but she felt the same as she did with Lyme disease. So now I was able to differentiate and say, listen, you came to me as a Lyme disease patient. You have the same symptoms you did when you get diagnosed with Lyme, but that mechanism is gone. You still have foods that are reacting, and when you eat them, they trigger the same symptoms. And those symptoms are autoimmune neurological symptoms. And that I only can find that out by running some food testing and some neural zoomer testing to see, are you reacting? Is this something I can completely eliminate by changing your diet, healing your gut? Or is this something we have to be sensitive to because you have a taste for you? You have a taste for your own neural tissue, and we have to push harder at calming down, Th17, Th2, and inflammatory markers. So I don't go right to all the tests all the time. But if I suspect an unresolving neurologic case, the patients are frustrated, they've done a lot of things, they don't want to continue to spend a bunch of money on guesswork, they'd rather know exactly what they're dealing with. A neurozoomer can confirm an autoimmune reactivity prior to a confirmed autoimmune disease. So that's a clinical presentation. Every patient does not get a neurozoomer. Every patient does not get an infectious disease panel. But if we suspect that, a lot of times it's beneficial to the patient for their wallet. So we're not shooting with a shotgun. We're much more targeted in our approach. So we'll do regular, what I call standard labs through LabCorp. And only when we need to escalate will we look at these. These are not part of the initial, hey, when you walk in the door, everybody gets all the vibrant testing. We do a fair amount of vibrant testing, but it's more of a confirmatory or an escalation clause for us.
Great. Excellent. Thanks. Do you want to keep going with questions, or
Sure. Yep.
More, but
I'm good with questions. Yep.
Great. It looks like there's a few that are specific to some of the markers here. So the first is, can the presence of anti-glucose be caused by an internal TBI, such as encephalopathy trauma?
Say again, I could barely hear you there.
Can the presence of anti-glucose be caused by an internal TBI, such as encephalopathy trauma?
Well, yes, you're asking, can it come from the inside out? Absolutely. You can have encephalopathy. What's the mechanism of the encephalopathy? So if you have a space-occupying lesion or you have an intracranial hemorrhage, whatever is driving the encephalopathy can certainly disrupt the blood-brain barrier. And then when you get disruption, remember you're breaking that wall of protection. Even a breach in the wall, the immune system has a tendency to attack it. So yes, it can be internal.
Great. The next question was, how often do you see certain antibodies, including anti-Purkinje, in cancer?
I lost you after antibodies. How often do I see certain antibodies to what?
Certain antibodies and cancer, and specifically including anti-Purkinje.
Well, so not as often as the literature might suggest. So cancer is a Th17 driven phenomenon in the body, and so is autoimmune disease. So both of those almost exclusively are Th17 dominant pathways. So they do run together, which is why you'll see some of the literature looking at antibodies in cancer. The problem is, once they develop cancer, nobody's looking at autoimmune disease. They're not even looking at that. So if we're looking at this predictively, we can look at some of those antigens and say, these are predictive potentially of cancer, breast cancer specifically. So I don't know that they come in with full-blown cancer and we're running these neural zoomers to confirm that. I think usually by the time that happens, we're focused more on total immune. Either way, we're trying to downregulate Th17 and Th2, which is going to support autoimmune disease and cancer. But usually at that point, the elephant in the middle of the room is not the autoimmune disease, it's the cancer.
Great. All right. Let's see. Any thoughts on the combination of anti-dopamine and anti-GABA receptors in a patient?
So that sounds a lot like the basal ganglionic loop and the indirect pathway. These patients are going to could manifest with emotional disturbances. They could have anxiety, but they can also have perseverations, that is to say, obsessive thoughts. They're very susceptible to that area of the brain is extremely susceptible to metabolic stress. So their mitochondria are going to suffer greatly because that area is very susceptible to metabolic stress with the immune system being active there. My concern is that is probably going to be neuroatypical behavior in some way, shape, or form. And early on, patients are going to find coping mechanisms and not address the underlying issue.
Let's see here. What symptoms do you see with patients that have Lyme disease?
That have what?
Lyme disease.
Oh, so Lyme disease, our office, we require all our providers to become Lyme literate doctors. And the problem with Lyme disease is it is as vague as anything. So there's only 7 conditions which cause migratory joint pain, which your shoulder hurts for a couple of days, then your hip hurts. Lyme disease is at the top of the list. You know, you can have other conditions like lupus, but they're less common. You can see things like brain fog. We've seen pretty much, we've seen paralysis, we've seen loss of vision, we've seen chronic migraines, we've seen extreme rashes, we've seen, digestive issues. We originally hired our therapist, our doctor for therapy. She was hired as a direct consequence for depression and anxiety secondary to Lyme disease. So there's a massive, it can really present like anything. It can disrupt any tissue. These are burrowers. These are spirochetes, which burrow. It's nice to think they just burrow in your elbow or your knee, which is great. But the closest cousin to Borrelia burgdorferi is syphilis, and tertiary syphilis looks like a moth-eaten brain. So these things really can, the longer they're there, the more damage they can do. They can trigger autoimmunity in brain, but they can trigger actual burrowing damage in the brain and look like your brain has a moth-eaten pattern.
Oh, wow. That's terrifying.
Yeah, it is. And so most of these patients, by the way, to come full circle, if you run the neurozoomer and we see neurologic autoantibodies and they have anxiety and they're told it's all in your head, just don't worry, go on an anxiolytic, you just need counseling, you just need therapy, maybe you need a drug that calms you down. But if the mechanism is an infection and that infection drove autoimmunity, your answer is not lorazepam. Your answer is get rid of the infection and drive down autoimmunity.
Sure, absolutely. And that makes sense. So Dr. Turnpaugh, we are right at time. I don't know if you had any additional information you wanted to share, or if you want to like throw out your website, if people want to, connect with you online anywhere, how could they get in touch with you?
Sure. Our website is turnpaughhwc.com, Turnpaugh Health and Wellness Center.com. Really the most interactive thing. We still we're dated, but we use Facebook. So Facebook, we post a lot of stuff on Facebook, and we're very interactive. If you have questions, somebody gets back to you pretty quickly. You can reach out to us through the website as well, but the Facebook is the most interactive piece we have. We try and share what we have. We don't think health is proprietary, which is to say we like to share everything we know, and hopefully people can take it and run with it. I think the big picture for this, my desire, I think that the NeuroZoomer Plus is a phenomenal test. I just think it may be underutilized in some and overutilized in others. For me, the way I use it, which is not the right way, but it's my way, is it giving me clues based on other testing? So do you have an autoimmune pattern which is relative to an infection or relative to a food? I think it's intimidating to try and look at the NeuroZoomer Plus in a vacuum. But when you look at the big picture and you say, well, is it helping me understand a mechanism of infection or toxin or mycotoxin, that makes a lot of sense. So we're here for the community of providers, as well as the community of patients. So feel free to reach out to us. You can, again, go to our Turnpaugh Health and Wellness Facebook page. We try and post as much as we can, and we're very interactive and get back to you as much as you can. I hope this has been helpful. I know it's a lot to squeeze in. I've done a 3-day lecture on brain, so it makes it hard to do in an hour, but I'm happy to share, and hopefully people glean something out of it.
Absolutely. No, this was incredibly informative, and we definitely thank you for your time tonight, Dr. Turnpaugh. So for those of you listening, we do provide the recording. Generally, it takes a couple of days for us to get that sent out, the link to you, as well as up in our portal. We will have the slides available as a downloadable PDF too. Thanks so much for your time tonight, everyone who tuned in. And Dr. Turnpaugh, thanks again for spending your evening with us. And we really appreciate all the information that you've provided. And I think that you connected a lot of dots here tonight for people who just really weren't quite sure exactly what role the Neural Zoomer Plus plays, or how to plug it into their process. So I think that's the biggest question you answered.
Well, thanks for having me. I appreciate everybody taking their Wednesday night and spending it with me. So I hope this has been helpful, and I hope it helps a lot of patients out there.
Thanks. Have a great night, everyone.